All right, so we're continuing with cataracts at this point. So this is lens opacity or cloudiness, right? Pretty straightforward. And I'm pretty sure you have family members who've had cataracts, right? So lens opacity or cloudiness, it can develop in one or both eyes. Extent of visual impairment depends on the size, density, and location in the lens. There are different types of cataracts. You do not have to memorize those. All right. So there's nuclear, there's cortical, there's posterior subcapsular, etc. And each of these shows up because of different things. For instance, the cortical cataract apparently is associated with a lot of sunlight exposure, whatever. But just know what a cataract is for your purposes. So normal clear lens. So now we're talking about the lens, right? That's what we're concerned about. And then this is a lens clouded by a cataract, right? So cataract is an opacity of the normally clear lens, which may develop as a result of aging, metabolic disorders, trauma, or it's hereditary. This is, I think on page 1894 is where the risk factors start. So it's chart 63-7. So there's so many, and they're categorized by, like aging, other eye conditions, toxic factors, nutritional things, physical factors, systemic diseases, and syndromes. So you just want to look at them just to see what could be a problem. The retinitis pigmentosa, this one is an inherited disease. It causes retinal degeneration and a gradual decline in vision. Okay. Nutritional factors, not having enough antioxidants, poor nutrition, obesity, etc. Your systemic diseases and syndromes, diabetes for sure, renal disorders. I can see how all of that is a problem. So a risk factor is just that. It's just a risk factor. And one of the major takeaways for cataracts is that you really have to minimize the risk factors as much as possible. If once you get the cataract, people will say, oh, if you eat this, it's going to go away. Or if you do whatever, it's going to be better. Or they'll say there's a special cataract diet. There really isn't, right? Your best thing is to never get it in the first place. And usually they don't like promote surgery routinely unless you cannot do your ADLs anymore, unless you're trying to drive and you can't see. That's when they'll usually do surgery. So surgery is only if your vision is really impaired and you can't do ADLs like you normally would. All right, so just keep that in the back of your mind. Versus for glaucoma, surgery, if we're not able to maintain our IOP, the patient's going to end up blind right away. So we have to do surgery for your glaucoma patients. You saw that was a normal consequence if the medications were not working. Okay, so it's painless, blurry vision. A person perceives his/her surroundings as being dim, almost as if your eyeglasses need cleaning. So the light is scattered, there's sensitivity to glare, reduced visual acuity, double vision, color shift, everything is looking more blue, and there's reduced light transmission going on. So healthy lens, the light's coming in, no problem, and this is what the patient with cataracts may be seeing. Very hazy. All right, so what this slide is trying to get at is the fact that like things like medications, eye drops, and eyeglasses are not necessarily going to cure or prevent cataracts, right? We know what the risk factors are, though. So what we have to try to do is we have to try to diminish those risk factors, and in the hopes that we never get cataracts in the first place, right? And initially, maybe your strong glasses may help and improve your vision. But like I said, if things get really bad, where everything is hazy, you're trying to drive, they are going to have to do surgery. But risk reduction is our go-to. All right. So surgery not needed unless poor vision interferes with normal activities. which is what I mentioned to you already. And the surgery is pretty quick. My dad actually had this. So it's outpatient, less than an hour, topical anesthesia used, insertion of an intraocular lens, IOL implant is done. If both eyes have cataract, surgery is performed on one eye at a time, usually with months separating the two procedures. So why do you think they want to do surgery one at a time? Well, you want to make sure it worked, number one. What if somebody messes up and now you're blind after you've had surgery? That's not good, right? So you want to do one at a time, make sure it's worked, the patient is fully recovered, and then you're going to do the other eye, right? So this can be anywhere from 3 months to 6 months. It depends on the patient and what the doctor is comfortable with in terms of spacing it out. Eye patch, glasses afterwards. Vision improves as the eyes heal. And remember, you have a chart that speaks specifically to this. I think it's page 1897. All right, so we're going to talk about retinal detachment, and I'm not going to talk about age-related macular degeneration at all. And I'm covering retinal detachment very loosely. When you're reading your book, you're going to see that there's 4 different types. We're not going to get into all of that. And then you're going to see that there's a whole bunch of different surgeries that they can do. Some of the surgeries will actually depend on the type of retinal detachment that they had. For our purposes, it's a separation of the sensory retina and the underlying pigment epithelium, and usually the result of a retinal break of the retinal tissue. Fluid accumulates between the 2 layers. Okay. We have a whole bunch of risk factors for retinal detachment. So things like increasing age, severe myopia, eye trauma, diabetic retinopathy, cataract or glaucoma surgery, family or personal history. I would want you to really be familiar with the manifestations, like what is different about retinal detachment from, let's say, cataracts, from, let's say, glaucoma. All right. So we have light flashes, floaters, cobweb or hairnet in the field of vision, painless loss of peripheral or central vision. They feel as though a curtain is coming across the field of vision. And the area of visual loss corresponds to the area of detachment. So this is how the patient would literally describe it. They would say it's almost like a curtain or a shade is basically in front of my eyes right now. Like they may say it feels like there's cobwebs and I can't see through the cobwebs. Floaters, all of that, and there's no pain also. Okay. So this is the treatment for retinal detachment. There's a whole bunch of different surgeries that they can do. The only one I think that you may see when they're asking you things would probably scleral buckling. So apparently this is an extraocular surgical procedure that involves indenting the globe, so the pigment epithelium, choroid, and sclera move toward the detached retina. I feel like this is usually what I've seen when I've looked at questions before. But once again, I'm not asking you any of this surgeries. And now we're doing nursing care of the blind patient. So for low vision versus blindness, so for low vision, just know that, like, loosely, it's literally the fact that the patient has visual impairment and they need to be using some type of devices basically to perform their tasks. For low vision, they're usually described as being having a best corrected visual acuity of 20/70 to 20 to 200. So they would qualify as being low vision. Okay. For blindness, it's best corrected visual acuity 20/400. So remember our Snellen chart. So 20/400 is pretty bad, and to no light perception, that they literally can't see anything. And then for the legally blind person, is the best corrected visual acuity 20/200 in the better eye, or visual field is 20 degrees or less. So remember, you have a wide normal peripheral vision that you should be able to see. And here, your visual field has been decreased significantly. Right? So yeah, so you're using some type of glasses, and still this is what's happening in terms of their visual acuity. Okay, and your different causes for low vision or blindness, any of this stuff. So diabetic retinopathy, macular degeneration, and under macular degeneration, older people, it can be dry and it can be wet. The wet macular degeneration is caused by abnormal blood vessels growing under the retina, and you see some pictures, but once again, I'm not going to cover it. Glaucoma and cataracts. These are just age-related changes in the eye, so you can just look at them loosely. And this is the AMD that I was talking about earlier. All right, so just for your frame of reference, so this is your macula way in the back in terms of your picture there. So this is the area that we're talking about. Okay. So you can read the slides just loosely if you want to. I'm going to skip them. When you are studying by yourself for the NCLEX, the only thing that I would mention is that between the two, between the dry and the wet is the worst one, because you have blood vessels that are being involved, and the wet one doesn't happen as much as the dry one. Like the dry one happens like in 90% of the cases, but the wet one is more deadly because you just have this funky blood vessels that basically grow, and not a good thing. Okay, wet one, retina, blood vessels under the retina begin to grow toward the macula. Big issue. Then we have other visual disorders, so you don't need to worry about any of this also. Okay. Then you get to the nursing interventions if you're dealing with a patient that has decreased vision, right? So there is a chart in your book again. You want to look at it. So things like identifying yourself as you approach the patient and before you make physical contact, right? All of this makes sense. So just read everything, and if there's anything weird, you can let me know. Things like specifying on the plate by using the clock position cues, offering to read written information, right? Nothing really weird. Okay. Asking questions like, how can I help you, or would you like me to help you?